Alright, week 4's lecture, post-intubation procedures. The good news is this is week 4 at the conclusion of week 4. As you guys know, you've only got 4 more weeks with me, so good luck with that. Just as a reminder, next week will also be your midterm exam on July 5th on Friday, so if you haven't already remembered that, you need to make sure that you're in Roswell, because you'll have both Rodney's and my midterm exam. So, post-intubation. First thing we'll talk about with post-intubation procedures is tracheobronchial suctioning. After a patient's been intubated, it is important to ensure that you're able to provide adequate ventilation and oxygenation. As we know, there's copious secretions in the trachea and upper airway that are there most times after intubation due to the patient not being able to guard and secure their airway for long periods of time. So we've got to figure out some way to get that out so we don't impair the oxygenation. The easiest way to do this is going to be to suction the trachea via the endotracheal. So there's some steps that we're going to do, and we will practice this in lab, to tracheobronchial suctioning. Number 1 is check and prepare your equipment like always. The next thing is we want to lubricate the suction catheter. Most times all we need to do to lubricate the suction catheter is going to be simply to lubricate it with some water, so forth. You don't necessarily have to lubricate this with KY jelly or anything like that, because it is going to go down pretty easily. We want to do our best to pre-oxygenate the patient. Especially after the intubation procedure, you want to do your best to make sure that the patient has received adequate oxygenation. You want to detach the ventilation device and put about 5 cc's or so. You can put a little bit more if you need to. Sterile water or saline down the endotracheal tube. The reason for this is, again, to loosen up some of those secretions and make them come out easier. We all have seen the snot and some of the stuff that we've coughed up in the past. You know, mucus can be pretty thick and nasty, so you want to do something to dilute that to make it easier to suction out with the little French suction catheters. So you'll then insert the suction catheter into the endotracheal tube until resistance is felt. If the patient has an adequate and still has a cough reflex, you want to go to the point to where the patient coughs. Stimulating the coughing reflex is a good thing, because again, that's going to help you to get rid of some of the crap that's deep down in there. So again, you want to go down to either you get the cough reflex or until resistance is met. You want to suction in a rotating motion. You want to swirl your catheter while withdrawing the catheter. You want to make sure and watch the patient's cardiac rhythm and oxygen saturation during the procedure, because again, you can induce hypoxia as well as stimulate the vagus nerve and potentially cause some cardiac dysrhythmias. You want to reattach the ventilation device and resume ventilation and oxygenation. So here you can see just some diagrams there for you to go through, preparing your equipment, lubricating the catheter, oxygenating. Now you can see going down, withdrawing with the swirling motion. You notice that when you're withdrawing is when you're going to activate the negative pressure. And again, at this point in time is when you're going to reattach the oxygen and reventilate the patient. So suction apparatuses. You have fixed or either fixed or portable mechanical suction devices can be used when performing tracheobronchial suctioning. As we know, the fixed suction units are permanently mounted on the wall of the ambulance and operate off a vacuum generated by the vehicle's engine manifold. These are what would be preferred to use, because again, you have the ability to dial in more exact pressure than using one of the portable suction devices, which oftentimes just have one setting, which is a medium-high setting typically. Fixed suction devices should be capable of usually having 40 liters per minute and a vacuum of at least 300 millimeters of mercury when the suction tubing is occluded. The portable mechanical suction device, whether powered by oxygen, air, or battery, usually does about 20 liters per minute, which is usually effective for us. So either fixed or portable suction devices can be used when performing tracheobronchial suctioning. And the portable mechanical suction devices, whether powered by oxygen or air, should be able to, again, take about 20 liters per minute. We'll use them. So here you can see portable mechanical, or again able to do about 20 liters per minute. And we have the selection of your suction catheters. For tracheobronchial suctioning, the soft flexible suction catheter, also called a whistle tip, can be used. Again, where you're not going to be able to stick a yonker down the middle of an ET tube, so you're going to have to use the whistle tip. The whistle tip is designed to slide down the ET tube pretty easily. It has holes on the side there towards the distal end to minimize trauma to the tracheal and bronchial walls. And there's a port at the end that will allow you to occlude it with your thumb and activate that negative pressure as you withdraw the catheter. Again, you want to typically lubricate the tip with a water-based lubricant, or with water, whichever, or your saline solution, just to make sure that it slides down easier. So again, it is designed to slide in easily, and again have all of the ports to activate the negative pressure, as well as numerous little ports at the end to help with suctioning out those secretions that are in the airway. Things that we need to remember when we suction: you want to limit the time of suctioning to a maximum of about 15 seconds. Anytime we're suctioning, realize that the patient is going without oxygenation. So again, we want to do our best to limit suction attempts to no longer than 15 seconds. We always want to make sure that they're on a cardiac monitor, because you can stimulate that vagus nerve, and as well as the fact that we do have the patient in a hypoxic state. And when the patient's in a hypoxic state, realize that we do run a higher risk of some of the FLBs or dysrhythmias. So also make sure that you have them hooked up to pulse oximetry, and use the pulse oximetry to help guide your suction attempts and how long that you're in. So preoxygenation is key prior to suctioning if we have the time. Anytime we perform a tracheobronchial suctioning, we want to make sure that we have the patient pre-oxygenated for at least 5 minutes, if the case warrants that. Realize if we have all kinds of secretions bubbling out of the ET tube and all kinds of other things going on, we may need to not follow this 5-minute rule and get in a little bit quicker and get them suctioned out. But you do want to pre-oxygenate the patient with 100% oxygen as long as possible, or as close to that 5-minute period as possible, to again bring up their oxygen saturations. This is important to remember the whole time you were preparing to intubate, doing the intubation procedure, so forth. We maybe were not providing the most effective ventilations prior to the intubation, and then during the intubation the patient was apneic, most likely. So some suctioning techniques. Prior to suctioning, we may need to again put down 3 to 5 milliliters of sterile water or saline. I prefer saline just due to the fact that it is easier on the tissues. Water can be somewhat hard, even in a sterile water can be somewhat harder on the cells. So again, saline works out better, but again, it'll help you to loosen up any thick secretions. You've all probably seen some lung butter or coughed up some lung butter yourself, and know that that stuff can be pretty thick, and it does have a tendency to clog up your little front suction tube. So again, if you can loosen those secretions up just a little bit, it makes things better. Again, once you get the pre-oxygenation done and I have put down the solution, you go ahead and put your tube down to start suctioning out the contents. You want to remember, just like any other type of suctioning, you want to activate the suction on removal, not during insertion. So you'll activate the negative pressure by covering up the tube or the proximal port as you're removing the device. You also want to remember, as you're removing the device, you want to rotate, not just come out in a straight motion, because again, you want to try to swirl and get at all angles as you're coming out to suction out all of the contents and secretions that you can. Again, once you get them suctioned, you want to hook them back up to oxygen as soon as possible and begin ventilations again. Because again, while you are doing this procedure, the patient is going with oxygen. So, like I've told you guys before, and you guys are going to, I have started figuring out with lab, intubation is a monkey skill. A monkey could do intubation if we really train a monkey to do that. All right, but the most difficult part of that intubation is the decision-making process surrounding the procedure and monitoring the procedure after it is actually performed. So there is no single test for tube placement that is 100% accurate. The most accurate way to determine tube placement is to actually see the tube pass through the glottic opening and watch that as it occurs. Seeing that tube pass through that glottic opening is going to be your hallmark sign to know that your tube is in the right place without any issues. But we do have some other techniques that are out there to help us with monitoring and verifying and correlating to ensure that we maintain that tube placement. Take a minute and think about some of those before we move on. What are some possible methods we can use to verify tube placement and to confirm tube placement?
Just listen to your lung sounds. That should be all we really need.
Lung sounds work out very well for us. Hearing that the air go in and out of the lungs, not hearing any gastric sounds, is definitely a good strong point for us. With the advent of End-Tidal CO2, that is the gold standard behind actually visualizing the vocal cords. Is going to be your next best method. And not just using your EasyCap End-Tidal CO2 monitor, but actually hooking them up to continuous End-Tidal CO2 monitoring.
I do have a question about that. After we get the ET tube in place, are we supposed to oxygenate the patient, or immediately after intubating, are we supposed to put the T-bar for the End-Tidal CO2 and then bag the patient?
Usually the best thing to do is, if you have colorimetric, go ahead and use colorimetric at that point in time and bag. If you don't have colorimetric available to you, then go ahead and put the T on for your End-Tidal and begin ventilating. Really, truthfully, while you're intubating, it would be ideal if your partner prepared your bag valve mask with the filter line attached onto there, so that way you just attach it on directly. So when we perform again, endotracheal intubation, seeing those tubes pass through the vocal cords is the best thing. That's what we're striving for. That's what we're looking for. But as we know, we have patients that have Mallampatties at 4. We have patients that we may just simply intubate based on the fact that we think we're in the right place and we just cannot visualize those cords. Or what about cases when we do nasotracheal intubation or a digital intubation? You're not going to see the tube pass through the glottic opening, so we have to have other methods available to us. The other important thing to remember is, just because you got the tube in the right place to begin with does not mean that the tube's going to stay in the right place for the rest of the time. Anytime you move the patient, you run the risk of dislodging the endotracheal tube. And there's nothing worse than having a patient intubated, and 20 minutes later when you're arriving at the ER, you walk in, the doctor listens to lung sounds to confirm your placement, and come to find out your tube's been dislodged and you don't know when it was dislodged. So anytime you move a patient, you need to make sure that you're verifying that the tube did not move. Like I told you in endotracheal intubation, and we will be practicing in lab as we continue on with this, is anytime you intubate someone, you need to put a C-collar on them, whether it's traumatic in nature or not. Because by immobilizing the neck and keeping their neck from moving, you, again, keep that airway neutral in line and lessen the risk of dislodging the tube. Repeat visualization is an excellent way to confirm tube placement. Repeat visualization is a technique to improve visualization of the glottic opening in intubated patients. It alters the direction of the tube and provides a better view of the passage of the tube through the vocal cord. Again, whatever you can do to make sure and continue to see that. Technique to improve visualization of the glottic opening is to gently displace the tube posteriorly towards the palate. Again, this action will alter the direction of the tube and provide a better view of the passage. Another way that you can verify placement and see what you're doing is to use a bronchoscope. Not everybody has a bronchoscope available to them. But again, if you can insert the bronchoscope down the lumen of the endotracheal tube and actually see those tracheal rings in place, you know you're in the right place. Because the trachea has rings, the esophagus doesn't. So if you see rings, you know you're in the right place. So I guess it's kind of a Lord of the Rings kind of thing. Okay, there's my bad humor for the evening. All right. So as was brought up just a minute ago, auscultation is another great tool for us. Auscultation's been around as long as medicine's gone around. As long as you can hear.
Instead of using the bronchoscope, you can completely eliminate it by using the endotrawl and increase the curvature as you're intubating and actually feel the tracheal rings.
You could do that, or you could also pass another technique you could use is to pass a bougie, which is a gum elastic bougie through there, just like what you're saying with the endotrawl. But you can actually pass that bougie down along and actually feel those rings rub across.
And then pass the tube.
Yeah. So that's a good recommendation as well. Auscultation has been around since we've been around. It's still a great tool for us to verify tube placement, but it can be difficult. Realize most of the time when we have a patient intubated, we are in the back of an ambulance driving down the road at 80 miles an hour in an ambulance that's built on a truck chassis, which vibrates and makes tons of noise, and your partner or your driver's in the front playing with the siren and playing with the air horn, making it almost impossible to hear what's going on. But again, auscultation is there. We just have to train our ears to be able to hear over all that motion. You have to be able to focus your chi. And if you haven't learned how to focus your chi already as in EMS, you need to figure out how to focus and tune everything else out when you're auscultating. I know it's a lost art form for an EMT, and how dare I even say this, but to take a manual blood pressure with a blood pressure cuff and a stethoscope. But I truly believe that lost art form has made it more difficult for us to even auscultate lung sounds, because we don't know how to tune everything out in the back of a truck. So also large patient size can also make listening and auscultating a little bit more difficult. You know, I'm a big boy. I have a big chest wall, so it's going to make barriers for the chest for my lung sounds to travel through. Sometimes movement of air through the esophagus can make adventitious breath sounds. Sorry about that. I thought we had a little glitch and stopped recording. We want to make sure, and just like you learned in patient assessment, we want to listen in 6 places. The right and left apices in the mid-clavicular line, the right and left bases in the mid-axillary line, and over the epigastrum and at the sternal notch to verify our lung sounds. Now, this auscultation is a little bit different than listening for diagnostic purposes, because we know for diagnostic purposes we are typically listening posteriorly. In this case, most of the time when our patient is intubated, they're going to be laying supine. So again, we want to listen to these spots. We should hear bilateral equal sounds in all fields, a quiet stomach, and a rush of air with ventilation at the sternal notch. More than any single auscultatory finding, gurgling in the stomach is going to indicate to you esophageal intubation. So if you have gurgling in the stomach, you probably need to go ahead and pull your tube, because typically speaking, even if you have a cup that's underinflated or a leaky cup, it's not going to produce gurgling. Gurgling is going to be only produced if you have an esophageal intubation or you have intubated the hypopharynx. Another thing that we want to do is observe and palpate the chest. Actually seeing the chest rise and fall with each breath is going to help us indicate that we have proper tube placement. If the chest moves symmetrically during each ventilation, we know that we probably have proper tube placement and we can move forward with this. The other thing we can do is actually place our hands on the thoracic cage and actually feel for chest expansion and equality. We should also be able to palpate the thoracic cage to feel the separation of the ribs. as the chest wall expands. We should feel those ribs start to pull and withdraw out. Also verifying that we have proper placement of the endotracheal. Now, moving into the gold standard, End-Tidal carbon dioxide, End-Tidal CO2. Great invention for us, great diagnostic tool for both diagnosing patients with medical conditions as well as verifying tube placement. But as we know, the continual presence of carbon dioxide in the patient's exhaled breath is the established standard for confirming endotracheal tube placement. That is the gold standard. Right behind seeing the tube pass through the glottic opening, this is going to be it. Seeing the presence of carbon dioxide is going to indicate to us that the tube is in the trachea. Sometimes we can get false readings. Realize this. If you have a patient that just went to Allsups, drank a 44-ounce honcho of cola, coated right after the fact, realize he's going to have CO2 in his stomach. Even when you get in his stomach, you're going to get that high first initial burst of CO2, but realize that's only going to last for a short period of time and then it's going to go away. If we are in the lungs, we should see a continuous flow of CO2 out of the trachea, as we know that that is an end product of metabolism. The continued presence of more than 2% carbon dioxide in the exhaled breath is considered to be a positive finding. Because no respiration occurs in the stomach, again, the presence of CO2 indicates the tube is in the trachea. The most common cause of false positive results is from the tube not being inserted far enough into the trachea. And again, we also may have a disruption in pulmonary blood flow. If you have a patient that's in cardiac arrest, realize that their CO2 levels are going to remain low because you're not bringing any CO2 up to be discharged. That's why Dr. Levine in his study back in the late 90s, which this has been challenged many times and proven to be accurate, that any patient in cardiac arrest who has an End-Tidal CO2 reading of less than 10 after 20 minutes of resuscitation attempts, if their CO2 levels remain below 10, there is zero chance of survival. Because again, they are not metabolizing, and 20 minutes of time has gone by, they're probably not going to change in that. So a capnometer is a device that measures the amount of carbon dioxide in expired gas. Capnometers are either colorimetric or electronic. Most of the time we have a combination of both nowadays. If you have colorimetric, it's usually best to pull those out right at the beginning and verify them. Basically, they work off the principle of a litmus paper. We'll talk about those in the next slide here. But they are End-Tidal CO2 detectors. They come in a foil pack. Usually it's good to keep them with your intubation equipment. You pull them out. They have litmus paper. As CO2 blows out, because CO2 has a lower pH, it's going to change them. In the presence of carbon dioxide, purple changes to yellow or gold. The way I always remember it is gold is good. So yellow is good, purple is bad. So if you've got CO2, you're going to get yellow. The reaction is very quick, and it should occur as soon as you hook them up without any delay. They don't make quantitative measurements. That's the downside to colorimetric capnography. With more than 2% carbon dioxide in the gas sample, the color change is dramatic, so we know we're good. But even if we have a concentration of 0.5 or 0.05 to 2%, we may still get some color change. It'll just be incomplete, and it can be more confusing for us. It's important to remember that the device becomes ineffective when exposed to room air for more than a few hours, and if we have the patient on hooked up to a patient for 15 minutes. It will continuously change color for about 15 minutes with each breath. We inhale, the patient it'll turn purple. As we exhale, it'll turn gold again, verifying that we're good. But again, if you leave it out for more than a few hours, it's going to lose its effectiveness. Electronic capnometers, they're out there on the market for us. They detect and calculate the amount of carbon dioxide in the exhaled breath. They have an adapter that fits between the endotracheal tube and a ventilation device. It typically looks like a little T. The great thing about the electronic capnometers is they actually quantify the carbon dioxide for us. Quantify mean they give us an actual number. The End-Tidal CO2 monitors that are colorimetric are what we call qualitative analysis. It's just, is it there or is it not? This is actually going to give us a good number to deal with. The amount of carbon dioxide is displayed quantitatively or with a bar graph of LED lights. Not only does it tell us that we're in the endotracheal, that we actually have endotracheal placement, but it also tells us, allows us to monitor PaCO2, which, as we talked about, will help us in our diagnoses. Knowing that the patient has a high CO2, we're going to anticipate that they're going to be in an acidotic state. So again, this will help us with confirmation of that and with diagnosis of other patient conditions. The End-Tidal CO2 is about 5 to 6 millimeters of mercury below the PaCO2. So that's how it correlates. So realize if you have an End-Tidal CO2 of 50, realistically, if you drew their ABGs, they're going to have an End-Tidal, or a PaCO2 or a partial pressure of CO2 of 55 or 60. So realize that there is a correlation there. So again, it will allow us to make adjustments to minute volume to maintain a normal PaCO2 during ventilation. So if you just took the patient up to the ventilator and you're getting a PaCO2 reading of 60, what do you think you probably need to do with your ventilator settings?
Increase respirations.
Why do you want to increase respirations? You're absolutely right, but why do you want to do that?
You need to rid the body of a little bit more CO2.
Right.
Create a more alkali base.
There you go. So you want to blow off the CO2. So what if you've had hooked somebody up to the End-Tidal CO2 and you got them on the ventilator and you find out that their PaCO2, or I'm sorry, their End-Tidal CO2 level is 27.
You blown up way too much CO2, so you're acidotic. So
Not acidotic.
Alkalotic.
Alkalotic.
So you need to reduce your respiration rate.
There you go, to hold on to CO2. So see, this is not rocket science. This is easy enough to figure out and to do. All right. So this is why CO2 is such an important thing for us. The best part of CO2 is the actual capnograph, however. Because the capnograph is going to plot the level of CO2 in a gas sample on a printout known as the capnograph. It's our version of the EKG. Rodney likes EKGs because Rodney's the cardiac man. I'm the airway man. I like capnographs because that's what tells me things. It tracks trends and quickly identifies problems. It also helps us to guide our ventilation rate and depth to make sure that we're maintaining an End-Tidal CO2 value of 35 to 45 because we know that that's what's normal, and maintaining those levels in a normal rate. So your steps are going to be detach the ventilation device from the endotracheal tube, put your inline capnograph or capnometer in the proximal adapter, reattach your ventilation device, and then monitor your capnograph. So there you can see it in picture form of how to actually do this. And you can see in this picture that we start out with purple when we're using a colorimetric, and we end in gold because gold is good. We have esophageal detection devices. They've been around for a long time. They're not the greatest things in the world, but they do help us. Because the trachea is a rigid structure that is non-collapsible. The esophagus is a flaccid tube that only expands when something is placed inside of it. So we cannot draw air when negative pressure is applied to the tip of an endotracheal tube in the esophagus because the walls of the esophagus will occlude the tip of the tube, if that makes sense. So if you've got the tube placed in there, or if you have a tube in the esophagus and you go to pull on the syringe, you're not going to get any air out.
Collapse on it.
Yeah, it's going to the esophagus is going to collapse down on it and include that tube. If you're in the trachea, obviously, when you pull back air, you're going to get air is going to maintain there. Okay, so we can always draw air out of the lungs by applying that negative pressure. So this is how esophageal detection devices work. You have two different types. Basically, you have the syringe type, which again is you're actually sitting there and you're pulling. And it's not pulling any air if you're in the esophagus, but if you're in the trachea, you're able to pull air back. Or the other method is what I call the turkey baster, and that's what it is. You basically squeeze it. It's like a bulb or a suction bulb, like you use on an infant. You squeeze it, hook it up to your endotracheal tube. If you're in the esophagus, it's going to stay collapsed. If you're in the trachea, it's going to fill back up with air because it's going to withdraw that air out with negative pressure. So, again, realize that the tube in the esophagus, that vacuum is going to be created as you pull back, which is going to prevent that air from filling that tube. With a bulb model, the bulb is collapsed and attached to the end of the tracheal tube. The bulb will remain collapsed when the tube is in the esophagus, and the bulb will expand if it's placed into the trachea and it's got proper placement. The main thing to remember about this, though, is if you've got a patient that's got a ton of air in their stomach due to poor ventilation technique, a lot of times we will get false positive results, and we'll actually get a bunch of air that'll fill up that bulb during suctioning. It cannot detect main stem intubation or oropharyngeal placement. That's important to remember as well. If you're in the right main stem, this thing's not going to help you guide that. What's going to be the only thing that's really going to help you guide a right main stem intubation and detect that?
Auscultation.
Auscultation of lung cells. Absolutely correct. Another technique that we have available to us is transillumination. If you place a bright bulb at the tip of the properly placed endotracheal tube, the light should be visible in the midline of the neck at the level of the sternal notch, recognizing that the fact that you have proper placement and you're in the right place. There are a bunch of commercially available transillumination devices available out on the market. Again, that illumination is going to be achieved by passing the bright light through the tissue. And it'll also help us just during the actual intubation procedure itself. But when we use transillumination for a confirmation technique, again, what we're looking for is the tip of that light to be right there, right above that sternal notch.
Right on the sternal notch?
No, it's cricoid right down in here. Sorry, excuse me. Thank you for pointing that out. Right at the cricothyroid membrane. Which is superior to the sternal notch. The main advantage of the ability to judge the depth is to judge that depth of insertion. What we should see is that we're halfway between the glottic opening and the carina. The disadvantage to this is it can be difficult to see in obese patients, bull-necked patients. If you don't know what a bull-neck patient is, that's somebody that spent way too much time at the gym. Their shoulders are all big. They have a thick neck, and they say things like "Don't lie to me," things like that. You know, they're muscle men, muscle heads. And also, if you're in an environment like in the middle of July, like it is in southeastern New Mexico, that's 110 degrees outside, there's not a cloud in the sky, and it's about 3 o'clock in the afternoon, realize that the ambient light itself is going to prevent you from being able to detect this properly. Realize the absolute best assurance that a patient is properly intubated is to use the combination of all techniques, or the majority of these techniques. But again, you want to see that tube pass through the cords. Although any of the following techniques are generally not reliable enough to be used individually, they are important confirmation things that we can use. And in a combination, they will help us to verify things. Tubes that are properly placed will mist. But that's not in and of itself, by itself, enough to confirm tube placement. But if you are in the trachea, you will get misting in the tube. That is no dispute there. As air moves up, it's humidified coming from the lungs, so you will have some mist that will start to form in there. A patient that has a ton of gastric air in their stomach, however, will also miss their tube. So again, by itself, this is not the greatest confirmation technique for you. When the tube is in the trachea, there will be a small puff of exhaled air as the patient's sternum is depressed. If you depress the sternum, that negative pressure there, you'll force that expiratory flow. You can hear or feel that at the proximal end of the tube during that chest compression. That again is a good tool for us, but it's just one little technique to help us confirm that maybe we are in fact in the right place. If the endotracheal tube is properly placed, you may feel a pressure wave in the pilot balloon that can be felt with a gentle forces applied to the trachea just above the sternal notch. If we get right up here above the sternal notch and push, we can get a little pressure wave that you'll actually, if you're touching that pilot balloon, you can actually feel as you plate the pressure on that cuff, it'll force that air up. Again, it's something that's there that maybe with a combination of all of the above is just another little set of things that will help you know that yes, in fact, you are in the right place. All right. Seeing that a patient's pulse oximetry improves, and knowing that the tube is in the trachea also is a confirmation technique for you. If your CO2 or pulse oximetry reading was at 90%, you intubate the patient and now they're at 100%, odds are you've probably done something right. If the patient is able to make any noise by moving air past the vocal cords, realize that that is a bad thing. If you can have a noise being made, the tube is not in the trachea, and it definitely has not gone through the glottic opening. Also, if you intubate someone and you have stomach contents coming out of the tube, spewing all over you and spewing all over the ambulance and filling up your bag valve mask, you're probably in the stomach, not in the trachea. So again, all of those are things there to kind of guide you to know where your tube is in fact located at. So errors of tests, visualization, false positive results. Tube may slip out after visualization, poor visualization, misinterpretation of the anatomical landmarks. False negative findings of visualization is misinterpretation of the anatomic landmarks. Breath sounds are also a good one, but there are false positive findings with that. Gastric sounds can mimic breath sounds. You have transmitted breath sounds and transmitted bronchial sounds that move from place to place. So again, there are complications and pitfalls that we need to remember when using our techniques to verify. Now, continuing on with post-intubation management, ventilating the intubated patient. When we're ventilating patients that are intubated, you've got to use your experience. You've got to be paying attention to what's going on and maintain things. Slow respiratory time reduces the airflow and hemodynamic complications of positive pressure ventilation and keeps interpulmonary pressures low, reducing the chances of barotrauma. Here's the thing that we're to remember. When you have somebody that is intubated and we are ventilating them, realize we have a passageway from point A to point B with no outside interference. We have a direct connection. We've put a pipe basically from the outside down into the lungs, which means that we don't have to put as much air in to actually inflate things because we've just killed a bunch of dead space. So our volumes are going to need to be decreased. We can actually slow down our respirations because, again, we're providing 100% oxygen and we're also allowing for more effective and efficient ventilations. Bag valve mask, even with intubated patients, is going to be our most common method of ventilation in our typical patient. It provides a feel for the breathing by allowing you to judge the compliance of the lungs. That's a great thing about it. We know how well the air is going in, and we can feel the air going out, so we know things are working. You can time our ventilation based on the patient's breathing patterns. The problem with the bag valve mask ventilation is somebody's got to do it. So many times we don't have extra hands to do this. So that's why we also are going to talk about automatic transport ventilators and things. But realize bag valve mask, if done properly, really truly will help us. So again, we want to use bag valve mask ventilation devices. But again, we're going to slow our inspiratory times, our expiratory times, and also our volumes when we have a patient that's intubated. The other thing that we can use is flow-restricted oxygen-powered ventilation devices. The constant flow keeps interpulmonary pressures reasonably constant. We also have a pop-off valve or pressure valve that will remit pressures of greater than 40 centimeters of water, which will decrease the incidence of barotrauma. But realize if you have somebody that's got COPD or already has a weakened spot, we can still potentially cause a pneumothorax by using these devices. So we want to be careful when we use flow-restricted oxygen-powered ventilation devices. So for a patient that's breathing, as the patient breathes, it's going to trigger the device and it's going to allow air to go in. For somebody that's not breathing on their own, we push a little button, and it's going to deliver the air into the lungs as we push that button down. For breathing patients, the device is triggered again by that intrinsically generated negative pressure. It's kind of like the same principle as CPAP. The patient, there's constantly air flowing, but as that patient breathes in, it's going to force a little more air into their lungs. The flow restriction and pressure pop-off valves make it impossible to ventilate a patient with poor lung compliance, increased airway resistance, or heavy chest wall. So if you have a patient that's got asthma or any type of obstructive pulmonary disease, this is going to make it very difficult to actually get that air in. They're not going to work. You're going to hear alarms sounding, you're going to hear the beeping, all that other stuff, and you're just not going to get the compliance that you're looking for. So again, this is probably not going to be the device you're going to choose with these patients. Next thing we're going to talk about is automatic transport ventilators, and the best thing that I can tell you about automatic transport ventilators, if you haven't already played with one, is we're just going to have to play with them. I can lecture about it a little bit here, but there's nothing like setting it up yourself. So we will play with these in the lab. But they have numerous advantages over flow-restricted oxygen-powered ventilation devices and the BVM. The thing is we can set the tidal volume and the respiratory rate, and it's going to ventilate the patient automatically. It's going to do it all for us. One person does not have to be dedicated to the ventilator for the rest of the time, so we hook it up. So again, this is why we spend so much time learning how to calculate tidal volumes, how to do that stuff. We also have the ability on most of these devices to set the sensor on how much pressure we want, so we don't cause too much barotrauma. And the other advantage to this too is we can control the oxygen levels. We can actually put somebody on a 50% oxygen or 100% oxygen, which realizing that once we're ventilating these patients that are intubated, do we always have to give them 100% oxygen? Yeah, we can probably set them on a 0.5 FiO2. So ventilators are going to allow for that precise control of the air variables in the ventilation. They can be used on both breathing and apneic patients. And again, all patients once they get to the hospital are going to be hooked up to a ventilator. As soon as you get to the ER, there's probably going to be an RT standing by with a ventilator. Now, the point to remember is our ventilators are not like ventilators in the hospital. They're emergency transport ventilators. They aren't going to be able to do all these peak inspiratory flows, inputs, outputs, all this other stuff. They're not as high-tech as many of the ventilators that the flight crews have. But again, they are tools that are out there and available to us. Some ventilator settings require that the patient do some of the work of breathing, and again, they can be tailored to that. That's how they get in, and ours do not have the ability to do this typically in EMS, but again, you have to wean those patients off the ventilators. That's why with clinical decision-making skills on whether or not we should intubate a patient or not, a lot of that is going to be guided by the fact of whether or not we think that patient is going to be able to be extubated. is a 75-year-old male with COPD and you intubate him. What are the chances of him becoming extubated? Not very good. Typically speaking, you just probably signed his death certificate by choosing to intubate him. I'm not saying you made the wrong decision to intubate him, but in reality, we may never be able to get him off the ventilator because he's just not going to have the compliance or the ability or the stamina to ever be pulled off of that. Now, every once in a while, we're going to have to extubate someone in EMS. I strongly discourage us from doing this. If we have to keep the patient sedated after we've intubated them, great. Because sometimes we're going to have the patient, we intubate them, we start to fix the problem, because we've got them intubated and they're ventilating well, they're going to start to improve. And they may even regain consciousness. I don't recommend that we extubate. If we can avoid extubation, keep them sedated. But if we do have to extubate, this is how we're going to do it. When the patient's level of consciousness improves to the point where they are gagging on the tube, fighting the tube, bucking the system, biting down, we may actually have to extubate them. But again, if we can sedate them, that is going to be the key. There are risks to extubation patients. One of them is overestimating the patient's ability to be able to compensate after that extubation is done. Again, the intubation may be what's fixed them. As soon as we extubate them, they're going to go right back to the point to where they were before, and now it may be very difficult to intubate them. And again, like I just said, once we pull that tube, even if they were an easy intubation to begin with, there's no guarantee that you're going to get that tube again. So again, if we can avoid it, sedate them. Patients who are awake are at a high risk of laryngospasm when we remove the endotracheal tube, because we're going to irritate the vocal cords and the larynx. So as we pull that tube out, we're going to cause spasming of the larynx, which again is going to cause difficulty breathing. If the larynx slams shut, they're not going to be able to pass any air down into the trachea. So now the patient's not going to be breathing at all after we extubate them. So again, just like with everything else in medicine, we have to weigh the risk with the benefit. That's what's called medical practice and clinical decision making. So you need to do what's ultimately going to be best for your patient and what your anticipated course of action is going to be. So field extubation is going to be indicated when the patient is able to protect and maintain an airway, the patient's not sedated, and you are confident, and I stress again, confident, that you will be able to ventilate the patient and re-intubate if necessary. Also keep in mind, anytime you extubate someone, vomiting and laryngospasm is possible, so you need to be prepared for that. So you need to have suction available, you need to have your partner in the right place so that you can roll your patient towards your partner so they can vomit all over your partner and not on you. So when we extubate someone, we're going to hyperoxygenate, make sure that we get a good oxygenation on the patient. You want to explain the procedure to the patient so the patient knows what's going on and what to expect. All they care about is getting the tube out of their throat. So you need to try to calm them down and explain to them what's going on and what's going to happen. Have all of your equipment available, suction, ventilation, the equipment to re-intubate if you have to. But you need to have all of that out and ready to go. You want to suction the oropharynx to remove any debris, so that way when you pull the tube, they don't suck that back down into their lungs. You want to deflate the cup at the beginning of exhalation so that any accumulated secretions are not aspirated into the lung or aspirated into the lungs. And on the next exhalation, you want to remove the tube in one steady fluid motion, following the curvature of the airway until you get that tube out. So again, just your steps again to follow up: hyperoxygenate, confirm the patient responsive, lead the patient forward, suction, deflate the distal cuff, and remove the endotracheal tube.